All right, I'll ask you to begin wrapping up your conversations, please. And I'd like to do two things. So what we'll do is we'll do a technique. So I often go to meetings and people say, I get tired of getting yelled at by the facilitator to stop talking. So when it's time to transition, I'm going to raise my left hand. When you see my left hand in the air, please raise your left hand and wrap up your conversation. This is a signal to everyone else to raise their left hand and stop their conversation so that we can then refocus. And it's a very gentle way of bringing people back to sort of focus in the center. So again, we'll do that. So appreciate that. So then as we're making our transition then, we do want to look to medicated assisted treatment in tribal and in native communities, so American Indian, Alaska native communities. Our speaker did introduce himself as a member of the Bay Mills Band of the Ojibwe tribe. He's Dr. Joel Chisholm, and board-certified psychiatrist, internist, and addiction medicine provider, working as the behavioral health medical director for Cherokee Indian Hospital, and a private practice addiction medicine provider. Again, tons of credentials, and so just recognize that we are the speakers, the quality and the qualifications of the speakers that have been brought to help you in this discussion are exemplary. And so with that, please help me welcome Dr. Chisholm.
Thank you, Harold. Yes, hello. My name is Joel Chisholm, as I already mentioned earlier. I also wanted to thank the ATC and SAMHSA and everyone for putting this together. I think this is a really amazing event to have so many folks, so many wonderful folks, as we just learned in the introductions, coming from so many different tribes, addressing this really important epidemic disease that is poisoning our native communities. So I think it's really important that we can all learn from one another and come together in such a format like this. I also wanted to, before I get started, kind of talk a little bit about what my presentation is going to be about. I know we're really focused, as I learned in the introductions, about MAT treatment, and a lot of people are implementing that treatment. We'll talk a lot about that, but I really wanted to let you know that my presentation is going to be a little bit more big picture. I'm going to talk a lot about addiction, but kind of the growing pains that we went through in Eastern Band Cherokee in developing our programs. And and what we have found, I don't know what it's like in your communities individually, but we have found in our community that there's a lot of comorbidity, co-occurring addiction. We have a big problem with methamphetamine. Kind of goes hand in hand with opiate epidemic right now with us. We also have a lot of problem with alcohol and benzo abuse as well that kind of go along with that. So I just want to mention that this is not just going to be geared towards opiate addiction. It's going to be geared towards kind of all the continuum of care. And that will be the major theme here today. So hello? Okay. Yeah, I'm kind of a mover and a shaker, so I'm going to move around a little bit while we're doing this. I don't like standing behind the podium. So what we're going to talk about here today, and the objectives of this, is going to talk about, obviously, a treatment of opiate addiction, as I mentioned, as well as I said, other addiction types that we're going to be dealing with. And I'm going to use the term opiate addiction synonymous with opiate use disorder, just so everybody kind of understands that concept. And then we're also going to talk a lot about the recovery treatment continuum. This is going to talk about how we're kind of looking at it from a holistic perspective of how we're treating folks. And then I'm going to specifically talk, as I go through that continuum, what we've done with the Eastern Band Cherokee tribe. And this is a slide that will be coming up recurrently throughout my presentation. This is kind of demonstrates the continuum here. As you can see, you have the person coming in, and they usually get what we call a CCA, or Comprehensive Clinical Assessment, or ESPERT. That'll be done typically either in our primary care clinic through our recovery through our behavioral health consultants. That's within our integrated model in Cherokee. We also do this through our outpatient behavioral health clinic. These clinical assessments can be done, and then they're done in addition in our ER or anywhere else in our inpatient medical unit, wherever we can find folks that this would be pertinent to. And then by implementing that, that opens up what level of care would be needed, right? So if we see the severity of the disease and what we're talking about, then we can kind of go through about where we'd recommend that these folks go. They can go either directly into inpatient, which we would do, this would be a medical inpatient, right? And they would do a detox and a medical clearance there. They would also potentially get referred during that point for a residential treatment. And then at that point, the residential treatment could either be of two forms. Could be a short-term residential stay, which could be up to about 90 days. But we're very flexible with that. That's not like set in stone because we're not, needing a lot of billing to associate with this. So we're very flexible. It's kind of where the patient is in the process. And then the other thing we do with that is a long-term. We just implemented this fairly recently. I'll talk more about all our strategies on this, but our long-term program goes from the 3 months, for an additional 8 to 12 months beyond there. So it's about a year beyond. And then we talk about our second phase, which should be coming back in to the community, and that's our transitional housing, classically known as halfway houses. This is a supportive environment, requires participation, outpatient care, and then also you're trying to implement folks with employment and getting back into school. Then our outpatient model is our MAP program. We also have substance abuse treatment classes. We have a recovery center that offers a wide range of classes, from culturally based classes all the way to support classes for families and individuals who need additional support. And then our community resources, and we'll talk more about that as we go through the slides here as well. So real quick, I know we already talked about the epidemiology, but I'm going to run through these fairly fast. And thanks to the introductions, I only got about 15 minutes for my whole talk, so I'm going to run really quick. I'm just kidding. So this really just demonstrates the heroin increase. Obviously, we all know the opiate epidemic has increased. I really wanted to emphasize on this slide the increase of heroin coming in, because heroin was really what's killing people. We have no idea what's in heroin. Carfentanil, there's all kinds of different stuff that's mixed into it. Not to say that when it was prescription drug abuse, it was much better, but at least folks knew what they were getting. With the heroin, the rise of death rate's gone much higher. And we see pretty much all heroin right now in Eastern Band Cherokee, very few prescription drug abuse anymore. This just shows shows some mortality rates based off of 100,000 deaths per state. And this is Native Americans in these various states. You can see that Minnesota is very high on this list, as well as Washington, the state of Washington. So this was a slide I just wanted to show there. And a little bit more epidemiology here. I won't read through all these, but it basically talks about the increased numbers in general in the U.S. population and the significance and how this has affected Native American populations. We have the highest rate of substance abuse and dependence in the country. And in Cherokee specifically, we had 430 adults that were admitted to our emergency rooms or inpatient departments suffering from addiction and mental illness. And that was in the course of 1 year. We have actually higher numbers than that now. This was back in 2017. And then we talked about in 1 month in June, we had over 80 overdoses that presented to our emergency department. And that is not actually showing all the overdoses. A lot of those people don't come in the emergency department. They do in the community. They Narcan them. They might come back. They might not. Some people die in the community. These are just the folks that actually came through our ER. And then this slide kind of shows the comorbidity that we're talking about when we're talking about opioid use disorder. And these are things that we really need to be cognizant of, because I think some of us get so focused on the addiction that we kind of lose track of all the other things that are surrounding the addiction that we really need to be concerned about. In particular, we have a lot of mental health here, right? The whole PTSD, suicide, mental illness portion of this is comorbid with, I would say, probably 80% of our folks in Cherokee. I know the statistics are a little different in the U.S., but in Cherokee, I would say it's pretty close to 80%. So very rarely do we get someone who comes in who doesn't have something else that's going on that we need to be addressing when it comes to mental health and mental illness. And then we also have other various components. A lot of the folks that we have that have complications are IV drug users. And IV drug users oftentimes have infections from the IV drug use, and those infections go to their heart, to their spine, different places, and can cause death from that. So that is another big issue there. Then, of course, we are very active in treating hepatitis C and HIV, and that is even within our program, because the standards for treating hep C have changed considerably over the last couple of years. So now we can treat people who are actively using still, because before the recommendations were you had to be clean a year. I don't know if everyone remembers that or not. You had to be clean a year before we'd implement hep C treatment. That's no longer the case, because they realized doing that they were missing the people who are at the highest risk, right? The folks that are actively using IV drugs. And then the dental thing here is very important as well, because that is something that is a big issue as far as infection and for folks who are coming into treatment. So when we have somebody who's coming in, and I'll get more into this in a minute, but someone who's coming into our inpatient unit for detox, we're trying to address all their needs, because a lot of these folks have not been taking care of themselves very well, and there's lots of gaps in their health care that we're trying to address while we have them on the inpatient unit. And this really just shows the barrier kind of that we're dealing with in society between MAT and the primary care, the behavioral health aspect over here, how things can get really siloed. And we get kind of, like I said, so directed in one area that we're not really thinking about the big picture sometimes of what people need on both ends of this spectrum. Because obviously on this end, this could be a great opportunity, as I said, within what we do in Eastern Band Cherokee, to do the SBIRT, to do the CCA, to get folks into treatment. But you have to have that ready in your system in order to do that. You can't just say, hey, go over to the clinic and get that done. People won't show up. You have to actually have it set up in real time where you're at with the folks. And this is our new hospital. This was completed in 2014. It's an amazing facility. It's got all kinds of cultural components to it, both in design, architectural design, and artwork, and whole influence of our model there. It's an integrated health model in Cherokee Indian Hospital. It's in a really amazing facility that was, like I said, was built in 2014. Cherokee has been independently run from IHS since 2002, and they have gone through a lot of growing pains with that. That was a very difficult transition. We've had to lean on IHS quite a bit through the years, through that transition, but it is independently owned and run. Behavioral health was taken over from the tribe to the hospital in 2013. That was also a big transition. Prior to that, we did not bill for any behavioral health services. It was all tribal, so it was kind of it was really not really run very well. There was probably about 14 folks there. There was no billing. It was kind of come in, you see folks, and you get what you get kind of thing. And then when we went under a hospital model, we really grew extensively. And the main focus of the hospital, every year they have 2 initiatives that they push, has been behavioral health every year until this year. So we've actually had 5 years running, where we've been one of the major initiatives. They put a lot of emphasis on behavioral health. And just getting to that point, from 2013 to now, we went from about 14 employees to over 100 employees in behavioral health now. So just to give you an idea how much we put into that. Also, the integrated model, as I mentioned before, I don't know if you guys are aware of this approach. It's very popular. We've leaned on South Central Foundation for their expertise on this. They've been doing this model for a long time. We're still working on this. This is not like a perfect system yet, especially from the behavioral health component into the primary care. A lot of primary care docs are kind of been there a long time. They've kind of done things a certain way, and they don't really want to grab that therapist to come in there and do some of the interventions that they could do or some of the things they could help with. So it's really important that the behavioral health consultant, we call them BHCs, that they're very proactive in how their approach is to the primary teams. Meaning they have to go out and they have to ask questions. They have to offer their services pretty regularly. That's a very important way. Right way training, I can't remember what this is called in South Central, but this is basically an approach to how we interact, not only with our patients, but how we interact with each other, right? How we work together and collaborate together. And that's not just within behavioral health, that's within all the different aspects of the hospital system. So this is about really kind of looking at things from a patient-centered approach, from a cultural approach, but also an approach that respects one another and how our personal relationships and how we connect with one another. Because that's really important when you're doing this work, because this work can be very difficult at times and can be very frustrating at times. And if you don't have those people around you that you feel like you can really lean on and work with, and they have the right intentions, then it can be very difficult. So we really worked hard to make sure our staff And all the folks within our programming are really emphasized on that training. And the CSU, that stands for Crisis Stabilization Unit. That's our inpatient psychiatric unit that we currently have been approved for. And that is being built currently. So that big, huge, and I'll show some pictures of this in a minute as well. That big, huge hospital that showed, there was a little smaller hospital, the old hospital, right next to it. And what we're doing is right now is we're basically breaking that whole hospital down, the old hospital, and we're building a two-level, two-story facility that'll be our completely behavioral health. So the bottom level of it will be all outpatient services, and the top level of it will be all inpatient services. And I'll talk more about that here in a second as well. And then this is about the behavioral health expansion. Tribal Council directed a substance abuse task force. This was back in 2014. That task force gave some recommendations about what they felt was important to move forward for dealing with substance abuse. And then we went ahead and do a QA process that was implemented for billing, so we could start billing for these services. And then we also implemented a outpatient behavioral health for detox and Suboxone programs, and enhanced those programs quite a bit, and really beefed them up. And then we obtained the CABHA status in September 2004. That facilitated Medicaid billing for us. And then the behavioral health consultants and the primary care clinics were in place, as I mentioned before. And then we also organized a structure to support the expansion. And then there's some other things. We hired behavioral health staff in the justice system. In the juvenile justice system, we added in-home intensive services. We have services in the schools, school-based services. And the Continuum, like I mentioned before, has been broadened. And this is some of the budget expansion for the programs that we've done as well. And then, so the Substance Abuse Task Force came back, and they reported back to Tribal Council in 2014. This was a group, both the folks from the hospital who are more kind of medical or clinical oriented, and then also our Healing and Wellness Coalition. This is a grassroots community organization. So we had input from the community as well as what they wanted. Come together and kind of from a clinical aspect and from a community aspect kind of coordinate together to see what we really wanted. And then, as we said, we were trying to develop this comprehensive continuum. We wanted to really develop a recovery community, and that's a lot easier said than done. I would say in Native communities, it sounds easy. Let's develop a recovery community. But when you don't really have one started yet, it's pretty hard to start one. So that's really where you got to go from the ground up, right? So when you have a lot of folks who are actively using, you don't have a lot of folks in recovery. There's not a lot of people to look at and say, I want to be like him or her. So really what we were trying to do is we're trying to implement folks with peer support specialists. As I've heard some folks mention in here that they're dealing with that in their communities. That's a great way to do it. If you don't have people in long-term recovery, you can get people that are only a year clean and get them in peer support positions and help implement them with some strategies to help kind of mentor other folks to help them in that recovery community. And then some of the other 15 recommendations came back, but the bigger ones that were in the recommendations were included were expanding child services, creating a substance abuse residential treatment program, which we did, and we'll talk more about that in a minute. Residential support homes, that's that transitional homes that was mentioned before, and a crisis stabilization unit. Getting back to this model, kind of looking at it again, what I've talked about, thus far has been a little bit of the big picture, but we're kind of setting the stage for what we're doing here in Cherokee. So here's the acute medical management of opiate withdrawal. We admit people through our ER onto our detox service. We give them symptomatic medications, kind of mentioned here, to kind of help them with the opiate withdrawal in this case. And then we decide whether this is more for they're coming off a detoxification or induction into our outpatient treatment center. What does this person need? What has worked in the past for them? Where are they at right now in their decision making as far as what they want to go in the future? These are all important questions we want to figure out, because that tells us what their motivation is for treatment number one, but also the severity of disease. So what works best for that person? Now, if you don't have a lot of resources, you kind of get stuck into one area putting folks in. But like I said, we're creating a lot of resources here. So we want to make sure creating those resources, we're putting the people who need it in the right places. And then there's that comprehensive clinical assessment that would be done on the inpatient unit in this situation. And then we'd want to assess for any untreated medical or psychiatric issues, as mentioned here. And then the final piece before they go into residential treatment would be a medical psychiatric clearance, which would be done by a psychiatrist or somebody on that level who would come in and then do that clearance for them to be set for inpatient treatment. Different styles of treatment we have. There's abstinence-based model. It's 12-step program, smart recovery, different aspects of that. Wellbriety has been mentioned. We have intensive outpatient program and IOP. We're still developing this. We don't have a technical IOP. Ours is actually more of a what we call an SAT, which is a little less cumbersome, I guess, for folks. And we'll talk more about that in a minute. And then the medication-assisted treatment, that's methadone, Suboxone, naltrexone. And then we have the residential inpatient treatment, short-term, long-term, and then transitional housing. Now we get to Matt here. So there's really three main versions of this, I'm sure, as most of you know right now. Methadone, which is with the traditional one. That's the daily dosing. You come in, you get your dose, and then you go home, and then you kind of come in 7 days a week. Cool thing about methadone, we are actually getting ready to implement a methadone program within the next 2 years as well, which was very controversial years ago, but it's really kind of come full circle. The cool thing about methadone is you have folks coming in every day. So they're actually going to get access to care every day, clinical care every day. So not just getting the methadone, but if you have your services set up around it, they can implement care on a daily basis, which is really nice. The other good thing about, or the other two really positives I think about methadone is that for certain people, they just do way better on it. I don't know what it is about methadone versus Suboxone, but certain people, they really require that level of medication. Suboxone just doesn't do it. They fail and they fail and they fail, and they get put on methadone, and their level of success is much higher. And the third thing, which I think is really important to remember, is co-occurring pain. If you have folks that have co-occurring pain and addiction issues, which is quite frequent, we have people that have been on opiates for long term, they do much better on methadone than they would do on something like Suboxone. So I just think it's really important that we kind of talk about that because I know methadone gets a bad rap a lot of times in the addiction community, and I don't necessarily think that's accurate. And then buprenorphine, that's Suboxone. That is obviously a partial agonist. Best thing I would say about buprenorphine, which is nice, is that it has a ceiling effect, right? And that, as this slide shows, it hits a certain level, and you don't get any more effect off it. So it doesn't give you the euphoria that you might get off a higher dose of methadone, per se. And then the other part about it is because of it having that partial agonist quality, it blocks against overdose, okay? Can't overdose on Suboxone. No cases of overdosing. Okay, so that's like, the idea that you're going to, overdose off of buprenorphine doesn't happen. And naltrexone is a nice option as well for people that want to go more the abstinence model. Now there's an oral naltrexone, but there's also Vivitrol, which is an injectable monthly version. The Vivitrol works, in my opinion, far better. The long-acting monthly injectable version. And anecdotally, we've been using it with folks that have been addicted to methamphetamine. We've had really good results with them, which is totally anecdotal, because but we actually have had really good results from folks that we don't want to put on Suboxone. They don't have opiate addiction issues, but we tried them on naltrexone, and they've done really well. Naltrexone is now on our formulary. It wasn't until this year. And Suboxone, by the way, wasn't on our formulary until last year. I'll talk a little bit more about that as well. And this kind of just shows you quickly what the receptor is kind of doing in these various points, the full agonist, partial agonist, and antagonist. And then it talks about the naloxone, which is not naltrexone. Don't get confused with this. The naloxone is the Narcan. That's like the Narcan kit we're talking about. That's what's in combination with buprenorphine to make Suboxone. And this is kind of talking about what are the advantages, what are we trying to do, and what does the evidence say of what we're trying to do about doing MAT treatment. We're trying to reduce overdoses and deaths, and then we're also trying to get retention of treatment, reduce recidivism, and reduce disease transmission, which is all very important. Now I'm going to talk a little bit more historically about what we've gone through in Eastern Bay and Cherokee. In 2006 is when Suboxone was first introduced. There were so many overdoses in that community. The tribal council said, you have to get something to stop all these deaths because people were just dying all over the place when opiates first came into that community. And I don't know how they came into the various communities in this room, but a lot of times when things come into a particular community, a native community, it comes in fast and hard. Like you don't have any problem, and then all of a sudden, you have like a major problem, like overnight. And that's really what was happening with with opiates. So when that happened, they gave the access. They got the primary care doctors, the waivers. They get the waivers. Told them, go out and get your waiver forms from the DEA. They did that, and they just started handing out Suboxone to everybody. Not really any restrictions. Here you go. Here's your Suboxone. Guess what? Death rates went down, and guess what else happened? People were giving it away all over the community, and it was a huge problem. So then everyone's like, whoa, wait a minute, now we're just drug dealers. We went from being the people saving everybody to being the drug dealers. So what I'm trying to get at is we really had to relook at everything. We had to put a lot more programming in place. So then we had made people start coming to meetings, and as the pendulum swings, it went all the way to the other aspect where we probably got a little too strict in our programming for a while. And we weren't allowing people back in the program that probably should have come back in the program because we were having too strict the guidelines. Or you didn't do the program right this time, you didn't do it that time, and now we're not going to let you in for another 2 years until you can prove to us that you're a good candidate. And that's way too punitive. We decided that was completely wrong. So when we did that, we started opening our doors, we started opening our aspects, we started really, like I said, opening the treatment continuum so we had different options for folks. We didn't just have one option for somebody who came in. We could offer them 3 or 4 different options of treatment that they could get to see which one that might fit them best. So it was a really important part of what we did. And then as we move forward, now we have 4 different providers, and there are 4 different half-day clinics, and they meet weekly. They have groups while they're meeting with the providers. They'll come in. There are different stages of the recovery. And I'll talk about the phases of our recovery in a minute, but we have different phases in our recovery. And depending on what phase they're in, they'll be looped into that group and come that day to see the provider. They're required to come to 2 of these group meetings a week. So they'll see the provider one day, then they just have to go to their group on the other day, which is a Tuesday and Thursday. And we have basically it's run by 2 therapists in our groups, and like I mentioned, we have the providers, which is a combination of family docs, PAs, and psychiatrists that manage that. We use the matrix model with a combination of the variety. We've kind of developed our own curriculum for our therapy approach. And this is what we're actually changing right now. This is what we're using our TOR grant money for, is changing some of this model around a little bit, our clinical service model. Because the way it was set up previously was that the tribe would pay for the first 6 months of Suboxone. And then you're kind of considered to be in long term, which, as I'm sure most of you know, 6 months is no time to be put in long term. So what we were doing was we were taking people that were in recovery for 6 months, in my opinion, still pretty early on in recovery, gone through the program, but as soon as we said you had to pay for your own, then they were kind of sent off on their own. To kind of go to their own meetings and come into the groups just once a month because they were paying for their own medication. It was almost like a graduation. Well, we realized that wasn't right. So this last year, we've actually put Suboxone on the formulary, and so it's paid for everybody indefinitely as long as you're on it, just like it would be if you're diabetic on insulin or anything else. And so when we did that, we're trying to implement now that we can kind of change our clinical services a little bit, designed for more people to get more services as they're going through treatment rather than getting less services, if that makes sense. So we're trying to get people more services past that 6-month mark and implement more meetings, more opportunity for group meetings. So what we're doing with our TOR grant, we're doing group meetings at nights. We're doing all various different combinations of childcare, of different ways we can get people into these meetings so they don't have these barriers, access to these groups that are so important for their recovery to continue. Because what we found is a lot of people, after they hit that 6-month mark and were put on self-pay, went right back into relapse and pretty quickly after that. So it wasn't like a model for success at all. And then we do what's called supervised medication administration. This would be considered kind of a methadone version of distributing the medication. So what we do with folks, rather than use methadone right now, we actually use Suboxone. They have to come in the hospital every morning between 7 and 8, similar to a methadone program. They get their dose. It's observed by a nurse. They make sure they take their dose. They can get a drug screen then if it's needed at that point, and then they're gone. Then they're done for the day. We help them with transportation to this. We give them transit passes, so people all have transportation to the hospital every day for free. And so by doing that, we're kind of, these are the people that are higher risk, that are constantly relapsing or just really struggling. We know that they need more intensive services, so that's why we're doing the supervised medication administration. And quite frankly, a lot of people stay in that level of care, and they like it because they know what to expect. It's formatted, and they know, hey, I can't do it on my own. If I go out there on my own with a 2 weeks of a prescription, I know I'm going to either use it all or sell it to somebody. So they tell us that, which is really good. And then we implemented medication-assisted treatment. It says September, but it actually didn't happen until December, January of this year. And that means that we started using Suboxone at our inpatient residential treatment program that was first opened in February of 2018. So it almost took us like 10 months to get MAT there. And that was just jumping through a lot of hoops, a lot of regulations about doing that. We don't have a lot of nursing staff out there, so having the nursing staff out there to actually give the folks the medication they needed was a little bit of some hoops to jump through as far as figuring all that out from a regulatory standpoint. One quick note on that, that folks who are, anybody who's ever doing this, if you're ever going to go to inpatient residential programs and use Suboxone, by the way, there's not many programs out there that do it across the nation. I don't think anybody in Indian country is doing it from what I know. I don't know, Dale, can you answer that? You are? An inpatient residential? Where's that? Okay, awesome. That's great. So what we've noticed, and you might be able to back me up on this, are you a physician? Okay. So the reason I'm asking is that usually when we induce somebody, we put them on, we give them like 1 dose of Suboxone, right, to see how they're going to tolerate it. And this is after someone's either in active withdrawal or they've been using before that pretty frequently. And when I've induced people out there on Suboxone, they've gotten very euphoric on it, which is normally not the case. People on Suboxone don't usually get any high from it at all. And they've been like very euphoric to the point it's been triggering for all the other patients that are in that program, because they're walking around really. And so I realize in saying that, it's just a teaching point for me to pass on to folks, is that I use very low dose now when I induce people that haven't been on it for a while. These are people that have been clean a lot of times for a month or two. They've either been in jail and came into our program, or they've been detoxed and came into our program, and they might even been in our program for a month already before we did the induction. So I'm just saying that you have to be kind of careful with the dosing if you are a provider and you're prescribing Suboxone. This is our intensive outpatient. I've kind of talked about this already a little bit. This talks about some of our statistics of folks that have come through it. These are typically people that are either sent there by the court system or they're affiliated with what we call family safety, which is our own tribal DSS, Department of Social Services. So we took that over. We took over DSS 2 years ago. So that's still a work in progress as well. Getting back to the Continuum, we've covered some different aspects of it now, more the outpatient model, but now I'm going to go ahead and get to the inpatient model. It's a 20-bed facility. It's located in Snowbird community. That's a small part of the reservation. They have basically, there's a larger boundary of Eastern Band, which borders Smoky Mountain National Park, and then these little communities that are associated that are also considered part of the tribal communities are located a little bit further out. This one's about an hour away. It's a beautiful spot. It's up on top of a mountain. It's a gorgeous area. It's got 16 beds designated for short-term and 4 beds designated for long-term residential. Now I'm saying MAT was initiated in January. It was really, that's more accurate. January, December was more accurate. And then what else? Oh, it's also eligible to other IHS tribes that live within the boundary, IHS tribal members that live within the boundary. I've mentioned the matrix well-variety treatment, and that's got 4 phases that go through the short term. And then there's a 5th phase that, if you're in the long-term program, is subdivided into 3 separate phases. And then one of the main things I want to emphasize is we have a cultural leader that works out there with folks, and that's probably the biggest aspect of our program as far as what really keeps people engaged and makes people really strengthen their recovery is the cultural aspect of what we're doing out there. It's a very important. So I would say anybody who's doing any sort of outpatient or inpatient, you really need to have that cultural component as a major factor of your treatment. And then we also do a work study base. That means the folks that are out there, even if they're in short term, they are working within our various programs, whether it's in our kitchen, doing the landscaping around the place, or just cleaning, like house cleaning. They all have jobs that they do every day as part of their treatment. And in the long term, they actually go out in the community and get jobs. So if you're in that long term 9-minute, we have all kinds of jobs set up within the community in that Snowbird community, which I said is an hour off the boundary. But we have all these jobs set up where they'll go and they'll work for half a day or a full day and then come back into the treatment program at night, which is also high risk, by the way, because they have access to drugs. So we have to be really careful when we do that. But side note. And this is just kind of giving a big overall perspective of kind of the spectrum of care of going from inpatient into residential, back into reentry into the community. I'm not going to go through all this. I think I'm kind of explaining that already. But this is kind of giving you an idea what the timeline is. But it's a very approximate timeline because, like I said, we really go with where the patient is. We're not going to push people through to hit any certain day mark. We're actually kind of going with where the person is at in the recovery, because some people might be much more motivated than others. And then some people might, pick up some other time in their recovery. So you have to be kind of flexible with this. This is a picture of our outside of our facility. I wish I had a better picture from the viewpoints. It's just an amazing spot up here. This is the going into our. So it's set up with a lodge and cottage design. We have a lodge that has like all the clinical services within the lodge. Where they eat, where they go to their groups, where they get their medication. Everything is within that lodge. And that's big enough to accommodate 40 folks. So we actually built it big enough to where if we expanded our program from 20 to 40, that we would actually be big enough. So and then we have 2 cottages that are 10 people apiece. So there's a lodge in the middle and then 2 cottages, and there's 10 men and 10 women in each cottage. And they share rooms. I mentioned the cultural keeper already as being a very big, important aspect of this. Family involvement is very strongly emphasized. And one of the things that we do watch out for is in that first phase, which is about a 30-day phase, we don't have much family involvement at all during that phase. That's allowing people to kind of get used to the program, not get triggered, not be influenced by anybody else that's outside of the program. Family members can, especially if you're an hour away, you can get really homesick on that first month. So we're trying to be very careful about not getting the family involved too quickly, doing it on the terms that makes more sense. I know that's probably kind of contradictory to a lot of folks in here what they're thinking, but we've really seen a lot more success doing it that way, limiting that family involvement just within that first 30 days of the program. And then the work, the meaningful work, as we're talking about, is part of the recovery process, making people feel like they're actually getting out there working, doing things to make them feel like they're getting some trades and some skills back, because a lot of folks haven't worked for a while that are coming in this program. We have educational opportunity, and then we also offer a lot of vocational. That's for like after they get out of the program. We're trying to give them aspects of training, whether it's training or just job opportunities if they already have a field that they're trained in. This just gives you an idea of total census. It's been slightly down a little bit. Before this, we were pretty well at capacity mostly, but it's leveled off a little bit lately. But this just gives you an idea what our numbers are like, men and women here, daily census. So women have always tended to be a little bit higher in our program than men. I'm not really sure why that is, but we always have women at capacity, and then men are always a little bit lower. So before, when we got our census at about 18, it'd be like women would have 10, we'd be all filled up, and men would have like 8. We did just graduate our first long-term folks. I think I might have mentioned that recently. A couple of them fell off right at the end. We had them all the way through a year of the program, and then right at the last minute, they kind of self-sabotaged themselves and ended up leaving the program. And then 2 folks just graduated last week, was our first 2 graduates. And then this is the transitional housing. We don't have this yet. This is something we're building right now. So right now, we're building a facility. The women's program is being built. That's for women and children. That will accommodate about 10 folks in that housing. And then the men's property, it's been very hard. It's very hard because a lot of folks don't want these places in their backyard. To be honest with you, that's really what we run into. We get a spot designated, and then somebody comes up with some idea why they can't have it there. And we kind of go through a lot of hoops on this. But we actually are constructing the women's home right now. So that's been a very big barrier. But this is basically the idea of like having that whole transition back in, right? Not just having someone leave inpatient residential, whether it's short-term or long-term, and going right back into their community, back with their family, whoever they're with, and expecting success. Sometimes you have to have a transition back into that. That means you have to have be able to come back to the community, get your job, deal with the stressors of life in a therapeutic atmosphere, right? And this is getting back to Continuum. We've covered most of it now, I believe. We're pretty close to all of it. And then here we're going to talk about some community resources. Mentioned the transitional housing, that recovery center I already mentioned. That's within Alanishki. That's our place where we have people come in. It's almost like a recovery living room. They can come in anytime, hang out, drink coffee, talk to peer support specialists, talk to vocational specialists, talk to anybody they want in that area. Just sit around and hang out and basically talk to folks that are in recovery. Have a place to go. Okay, that's the idea. Keep people engaged, keep them busy. One of the main triggers for relapse is boredom. Okay, sitting around too much, not doing anything is one of the main triggers for relapse. So we really try to emphasize it's very important that you stay busy, and part of that might just be coming to the recovery center and talking to folks. This is just harm/death reduction when you're talking about Lazarus Project. We implemented that back in 2014. We've given that out everywhere. We don't just do it through the pharmacy. It's everywhere. We give it out at any sort of recovery rally. Anything we do, we are giving out Narcan kits everywhere. We do that so there's no limit to it. And, you know, any family member who's even concerned, doesn't even live with another family, who's even concerned about it, we'll give them a kit, educate them how to use it. We feel like that's very important. And the other important part about that is, too, one of the educational pieces is that I really try to strive this, is that if you give somebody Narcan, you want to make sure you tell them that don't just give them Narcan, the person comes back and say, oh, great, this is awesome, they're all back now, they're not dead. They only last for about 10 minutes. So if you give somebody Narcan and the Narcan wears off and they are still in active, you know, overdose, they will go right back into it and they can still die. And that's happened in our community quite frequently because people think that they're okay just by giving them one dose of Narcan. So it's really important you tell them, if you give them Narcan, get them to the ER immediately. Don't wait. Call an ambulance. And then the needle exchange program was implemented by the tribe in 2018. We have over 400 participants in it. And I think it's just amazing. It's great, obviously, to reduce disease transmission and you know, death, but it's also really important because it helps us get access to care. You know, everyone's at a different place and where they're at in their lives as far as if they're ready for that change to commit to recovery. So if the needle exchange program is just another opportunity to give people access to care, where you can, you know, not that you're going to be preaching to them about, you know, not using or anything, but you're just telling them the resources that are available. If they ever want to use them, here's the resources that are available.
And Dr. Chisholm, I just want to know you're at 40 minutes.
Okay, thank you. Thanks, Bill. But, but anyway, so this is kind of talking about Island as a whole. This is the center that we're actually developing that'll take over that whole bottom level of that new hospital that we're building. So we're really trying to, you know, implement a huge recovery community within our behavioral health. So we're going to be doing all of our detoxes. All of our folks are going to be done in that building. We're no longer going to be going through the inpatient medical service when we do this is some of the plans for the future that we're talking about. We're developing our own crisis response team. This is basically getting placement for folks who are coming into the ER, who need placement, getting into mental health services. We've been contracting out with a local community-based program, and they cover the region, but they have a lot of other people that they're advocating for, so you kind of get caught on a wait list a lot of times for our folks. And so we want to have our own folks that are doing this for the tribe that have you know, our own resources, and this will help. And we're getting pretty close to implementing that part of our plan. The CSU, as I mentioned, is an 18-bed inpatient psychiatric facility. It's going to have a 14 beds for general psychiatric illness and detox patients. So that in itself is going to be a little difficult. I don't know how many folks have seen inpatient psychiatric units, but putting detoxers and psychiatric patients together sometimes doesn't always work real great. So that's going to be kind of a work in progress, and the clinical lines of both those are going to be completely different. So we're really going to have to work on that. We're actually in the process of kind of developing all that right now. And then the methadone program, as I mentioned, is projected to implement in October of 2020, as is the CSU for that matter. And that's, like I said, is just to offer a broader spectrum of care. This is talking about the crisis stabilization unit, our need for it. I won't go through all this because I think it's pretty evident that if you can have your own inpatient psychiatric unit for a tribe that has this many people going to the ER and inpatient units, it's obviously very needed within our own. The only problem with that is like when you have a unit that's that general, there's certain populations of patients that aren't going to be able to be treated on that unit. Geriatric, kids, IDD, all these folks that are very specialized, and those are the people that actually sit in ERs for 2 weeks or a month, so to get placement. So that's kind of the bummer about all that. We don't have that specialty kind of care that we'd like, but we're kind of do our best with what we have. That's because these are kind of like the architect's cartoon versions, but this would be our 2-level facility with that hospital like we just showed you earlier over here. And this is the back side of it, just so you can get an idea how it's going to be a 2-level facility. And there's the hospital on the other side, the new hospital on the other side of it there. And this is basically what we're implementing within there, the various spots that we're going to be using all that space for. So to wrap up, I know I was firing a lot at you guys from a big perspective. I was trying to hustle a little bit. And we can talk more on the table. I can answer a lot of questions about any specific questions you guys have about it. But basically, we're really trying to talk about how serious of an epidemic this is and what we've done in Cherokee to kind of implement what we feel like is really hitting a lot of the evidence-based continuum of care for treating addiction. Still working on it. We've had a lot of trials and tribulations on this, which I can get into on the panel discussion. And we have really been working hard as a whole in the community to really deal with something that's been such a huge problem, I think, in everyone's communities in this room. There's my contact info. Thank you.
All right, so thank you very much for that, Dr. Chisholm, and I'm glad you rushed through because it took you exactly 45 minutes to do that. When we come back to the panel, we'll do some questions because we do want you to take a quick look at the questions that have been put on the table. So there are a few, about 6 questions. There's just a few sheets, so we would ask you to share those and just have a brief conversation at the table. Pick that up, again, focus questions, but really take that conversation where you need to. And you are sitting next to Dr. Chisholm, so maybe you can start with your question. It might be a good one. But take a look at those questions, and we've asked the panel members, Daniel and Ted, to address those when they come forward. But we do want to encourage a bit of dialogue at the tables before we move to that part. So we're going to do this really quickly, so 15 to 20 minutes. Let me just check with them.
may have for tomorrow
Okay.
because of the snow.
Well, then how about we move me tomorrow to pick up that, unless he's out of hand.
No, let me see.
Oh, just only because we're about
Of course.
half an hour behind.
But her name is Shelley Campo,
Yeah. Oh.
and she was going to talk about how to create prevention campaigns, and we can ask her.
Here.
Yeah, she had to turn around and go back. She was at Albert Lee, but the snowing was bad.
Video her in or Skype her in?
I'll ask Jeff what he thinks. Yeah, and he, where is Paul? Paul was going to fly up. So he
we'll
may
see what
be able,
happens.
yeah. Because
Was there a possibility he may not be here either?
I think it's easier to fly than she was trying to drive, and I wanted her to hang out as much as possible today and tomorrow. But we'll see. She's going to keep us posted.
Yeah, keep us posted. And again, given time, if pulls the plug, that's what I would suggest. Otherwise, I think we're just going to be pushing pushing hard. I'm ready on this, but
we,
it's the easiest one to move.
Yeah.
Because I ain't going nowhere.
You're not coming and going
I'm not
anywhere.
catching a plane.
Is this on?
Yeah. We just have, okay. They're busy.
So it's
Yeah. No, no, it's good. A lot of people call. Some people call. A lot of people call. Oh, they're massive. Here's a pumpkin. By Hillary. Sample?
so what about was
See where we are on time, but if we need to move this, then we can move that.
yes.
Right? Because as I like to point out, I'm not going anywhere. And maybe not on Friday either.
Yeah. Paul also.
So Paul.
But again, then we could do some table conversation.
Yeah.
So,
And we back into it in webinar.
yeah. But Shelley for sure, right?
They are to provide
PowerPoint on the USB. Good.
Has it started snowing outside? I haven't either. So anyway.
Yeah. Yeah, so well, we'll put one mic there for them if they want to sit down. This one doesn't move, and then we'll use one mic for the floor. Yeah, so it should. I think we can ease up a little bit, right? So then let's go to 12:30. Take the lunch at 12:30 rather than 12:15.
What adjustment do you need?
Well, I think what we do then is we move me to Shelley. So that's the easiest one to move, right? Yeah, so then we go in there and then we'll still know about him, but I think what we prepared to do is we turn that into a dialogue session, right? So then by then we've covered a host of other things, but we haven't had a chance to talk about this.
We'll
So.
also have this panel.
Yeah. Okay. Yeah, and then, yeah, and by the way, data collection to performance measurements probably not a bad segue. Okay. Well, so lunch on their own, right? Lunch on their own? Okay. So I started them at 11:25, so I figured, was that 15, 15 minutes? Well, that's, yeah. So 11:45 is 20 minutes. Tables, that's enough?
I think 15 would be enough.
Okay. All right. Mm-hmm. and Dr. Chisholm, Captain Hall, and Daniel to come on up and grab those seats? Yeah. Did you see them? I see Daniel there. Okay, ladies and gentlemen. All right, ladies and gentlemen, perhaps a brief reminder about the left hand exercise. We know that's not a lot of time, but again, we also know that we're getting close to the lunch hour, so we do want to interrupt your conversations and ask our panelists if they'll come forward. So Daniel Dickerson, who's an Alaska Native addiction psychiatrist and associate research psychiatrist at UCLA's Integrated Substance Abuse Program, also providing services at the American Indian Counselor Center, and a principal investigator and co-principal investigator on a number of studies relating to the role of culture in prevention and intervention. And Dr. Ted Hall, who's a captain in the Public Health Services, Indian Health Services, and is the clinical pharmacist assigned to the Ho-Chunk Nation Health Department. He's been for about 17 years, and he also serves as a pharmacy section co-lead for the Indian Health Services National Combined Council's HOPE Committee for Patient Care and Perinatal Substance Abuse. And they'll also be joined, of course, by Dr. Chisholm. So the way we've asked them to do this is to provide some brief reflections and opening commentary and we've asked them to the degree possible, as we asked the tables, to speak to the questions that were put forward. And so the questions did deal, of course, with resistance, adaptations, with some of the details about being holistic through the continuum of care, and then just sort of this whole, I would call them messages of perhaps caution and hope that we need to provide to providers and families. And so with that, I'll turn to Daniel.
Yes, thank you very much. I'm Dan Dickerson. Uniarok is my Inupiaq name, Sigvan Koya, in Wainwright, Alaska. On my mother's side, I'm Inupiaq, father's side, Caucasian. I grew up in LA County. I'm sure this all makes sense. Just another example of the diversity that exists within the people that we serve. Just some general comments from my perspective and experience in providing MATs to the urban Native American community in LA. In general, there's a need, I think, for, we live in, maybe not exactly, but we live in two worlds, the traditional side and the Western science side. I think on the traditional side, our people, our communities, our elders, we need to be receptive to the knowledge that's out there with regards to addiction, the neurobiology, the treatments that are available, these evidence-based medications that can help our communities. We need to be open to this knowledge. And I think on the scientific MD, PH side of the world, we need to be receptive to the traditional teachings, the way that our elders and ancestors believe and operate in our modern world. So I think that's just a general comment I have. I think there's more need of a team approach. Often as a provider, I feel like I'm the lone soldier out there to give medication-assisted treatment. So what we need is, there's a lot of clinical directors in this room, clinical directors, program heads. I think it starts from the top. If you emphasize the need that we need to do this, we need to give medications to our people that could help them with their addiction, it's going to happen more than if you don't emphasize this as a priority in the way that we treat our people. Those are just some general comments I have.
Thank you, Daniel. Good morning, everyone. Heineck Chaiwada Hi P. I'm glad to be in here and be able to speak before all of you. So, my name is Ted Hall. I've been at Ho-Chunk Nation for 17 years, started there as a staff pharmacist. 2009, I got board certified as a psychiatric pharmacist. And around 2013, I entered into a collaborative practice agreement with one of our physicians so I can diagnose and prescribe for psychiatric and substance use disorders. So currently, I moved into the advanced practice pharmacist position, which is almost like a mid-level psychiatrist, and I'm running in a medically assisted treatment program at Ho-Chunk. And just to coattail on what Dan was saying, my general comment that I'd like to communicate is the systems approach and the integration. I'm going to be a little bit biased with pharmacy, but I feel like at Ho-Chunk, pharmacy has been able to be the bridge between medical and behavioral health, and it does take a whole community around the individual, truly patient-centered care and primary care behavioral health integration to support each other, because addiction is a very complex biopsychosocial chronic condition, and sometimes, when we're trained in the medical model or the behavioral health model, there's different jargon and there's different approaches and different understanding. So when you bring the teams together, you start really cross educating and being able to help support that individual. And then it gets out into the community. Because what we do in the facilities is an important part, but it's a very minor part. I always say that the best treatments and the best counseling may not be enough, especially if they're going out into a social environment, whether it's at home or in the community. One person can unravel the whole system if they're associating with somebody who might be very influential in what they're doing outside the community. So I'm going to go ahead and pass on from there.
Thanks. I've already kind of said a lot, but so I will say a few things that I thought of after we sat down at our group here, which I think are really important. Number one, I think it's important to realize that everyone's community is different here. No one's community is the same. So we're all going to be dealing with different issues, whether it's population, whether it's location, whether it's the level of substance abuse, whether it's cultural community barriers, whatever the situation is, they're all going to be different. So I think we need to realize that not one shoe fits all. Okay, all this evidence-based stuff is great, but it doesn't pertain to how we deal with our specific communities. So I really wanted to say that, and I think it's really important while you're developing these programs, because it sounds like a lot of folks are on the early end of development in their programming, that you really use the community and all the folks that are going to be involved with it as resources. Meaning, like when you're trying to design, what are we going to do about implementing MAT? I think it's really important that you bring in, an elder, you bring in folks that have battle addiction, you bring in folks, you bring in children, you bring in family members, you bring in the clinical people. You bring in everybody to sit down together and really talk about, and you're not all going to agree. There'll be a lot of people who are not going to be agreeing in the room, and that's okay. You're not supposed to agree. Okay, this isn't easy stuff to get through. So you're going to have to realize that as you're doing this, that there's going to have that collaboration on the front end is much better than just starting a program and then hoping everybody's on board. Because the buy-in's probably not going to be nearly as good as if you don't get the community involved and get them involved down in the front end of it. And then also, the other thing I would like to say is as you're developing these programs, not only is it important you collaborate on the front end with the folks that, that design the programs, but it's also after you get the programs going, meaning if you have your MAT program over here and you have your behavioral health program over here and you have your medical program over here and you have whatever community-based issues you have over here, like for instance, like we have the family safety, which is our DSS. You have to talk about these things on the front end. I think it's really important. What we did was we learned the hard way. We created all this programming, and then they got siloed really fast. They grew really quickly, and it was great. It was great ideas, and we thought we were doing the right thing, but we realized that there was a lot of people that didn't know what the other people were doing over here. So therefore, they didn't really respect what they were doing, because they just thought, oh, they're just over there. They're thinking that we're going to do this because of that. And they kind of go to, I call it going up your ladder. You kind of go up your ladder, making assumptions about stuff that you don't really know where they're really coming from, nor have you really looked at their perspective. And I'll give you an example. We deal with a lot of folks that are coming through family safety, and the court has one idea of what they think the person needs, and then family safety has got another idea, but they're getting pushed by the court, and then behavioral health, who they're telling to implement the idea, is over here, and we're like, no, we don't agree with any of that. So we kind of all get in these perspectives. We don't agree on things, and I think if we can sit down and, especially on the front end while you're developing these programs, and really talk about where you're coming from, what you're doing, what is the goal. Yeah, we're not going to agree, but how can we come to an agreement for it's best for this person, and not all of us to think that we know what's best. So I just think it's really important to kind of have that communication, that collaboration is really important.
Thank you very much for that. And I just wanted to just on that idea, Dr. Chisholm's, I think, covered the MAT and some of the considerations and the implementation challenges that might be out there. Maybe Dan and Ted, from your perspective, I think Ho-Chunk's a much smaller, still a considerably large tribe, 7,000-ish, but smaller than Cherokee. And then in an urban context, in terms of medication-assisted treatment, any other unique consideration or experience that you've had in your environment? And then we'll open the floor for questions.
And within our clinics operated under LA County Department of Mental Health, and they've implemented or beginning. I'm part of their advisory kind of work group that's looking to broaden the scope of MATs throughout the county. And in general, our providers, it's always amazing how often you hear that people have never heard of this, MATs, medications for that exist for alcohol and opioid addiction. So even providers, a lot of providers in our clinic never knew this. PhDs never knew this, the vast majority maybe. So it's been more of I don't know the word exciting, maybe not exciting, but very interesting, and a lot of enthusiasm for MATs in urban setting in LA, I could speak for. And they began to see the benefits of Vivitrol, naltrexone, medications I'm prescribing, even disulfiram I prescribed a few times. So there's hasn't been any overt, huge concerns thus far.
Thank you. Yeah, and Ho-Chunk is relatively smaller, but we also are not on one defined boundary of reservation. So we actually have trust land that's across Wisconsin, serving 16 counties. We have two main facilities in Black River Falls and in Baraboo. So we have two distinct healthcare teams of behavioral health and medical. And so even with our levels of integration and challenges within those teams tend to be somewhat unique. But as far as relative to the medically assisted treatment, it started off small like anything, grassroots. You have one or two providers working with a couple of behavioral health clinicians. But what happened was, as there were successes and as the community embraced and saw that we had some resources and help for alcohol and other substances, and we were working as a team in the clinics, it grew, and the other medical providers and behavioral health clinicians started coming on board. And then we learned from each other, and then we learned from the community. So myself as a clinician, and I've prescribed disulfiram a few times as well. It's not something that was widely used today for alcohol use disorder. That's when it gets somebody very ill if they drink alcohol while they're taking it. But the one key concept that I've learned is that you have to meet the person where they're at, listen to their story, and figure out and really listen intently to figure out what are those needs, how did they get there, and where are some of the things that they need today. And some of it might not even be something we can provide in medical clinic, but we can connect them to those needs. So in our smaller tribe, we've been able to just start rolling that out over the 2 clinics in the community, and even getting patient registration on board, because they're the key to the clinic. So having their approach of when somebody's coming in and they're in withdrawal and they have some aberrant or agitated behaviors, rather than escalating it, for them to come from a more compassionate, this is somebody suffering, they may need a little bit more attention than somebody presenting for strictly medical. So there's got to be education all the way down to your frontline individuals who are that initial access to clinic.
Great, thanks. So we do want to open the floor, so if there's any questions from the participants to our speakers, or if you want to reflect on the questions and your conversations at the table. And in particular, we'd like to hear from some of the smaller or remote communities on how it played. So I've got 1, 2, 3.
Good morning. One of the most important things that I think that we've got to remember is from the services that are provided on reservation into the urban setting, when your facilities cannot provide the immediate emergency medication for that individual, then you have to go off reservation, maybe 92 miles to take them in there. And then the key to that is that you have to have an advocate with that individual, whether it be a family, a peer specialist, or whoever, to stay with that person all the way through. Very important. It doesn't matter if you're staying there all night and sitting in the hallway waiting for somebody to provide service, and you're keeping that person calm until they can get the services they need. And then you're also advocating for the family, making sure they're okay. Are you tired? Go ahead and get a room. We've got a room for you. Don't worry about it. I'm here. That is a huge gap between reservation-based services going into the urban setting and being there, and you think they're okay, and then they turn around and they're released 3 hours later. You know, and so if you can get community-based advocates for the family people, the individuals, I think that's really, really, really key. Grassroots people who know the family, who know their situation, who know their community, who know maybe their language. And they can do the interpretation, because a lot of terminology that comes to them, they can't comprehend it. So you break down the terminology for them so that they understand. What are they talking about? They're going to help you. This is what they're going to do. So you calm them down. And then you're able to provide. I think that's a real key need, I guess. And that's what I wanted to share with you. Thank you.
Any comments, gentlemen?
Yeah, I'd just like to comment a little bit on what you said. Thank you. That was great. And that is so important, what you're talking about. And I agree. I think a lot of times, previously, in Cherokee, that's why we designed a lot of our programs to be more internal. But I understand that's not always the case in most tribes. And previously, we did have to have a lot of people go outside our facility to other facilities. We still do that quite a bit, but we didn't have our own inpatient residential. We didn't have our own psychiatric unit. We didn't have a lot of things. And people do fall through the cracks all the time when that happens, because they don't have that connection to the tribe anymore. When they go outside of there, they're just out there. And whatever happens, happens. And for some reason, the outside facilities think like when they come back to Cherokee, it's just a magical land where they just fall right back into the system perfectly and everything is right where it should be. And it never happens that way. So thank you very much, because that is one of the biggest gaps, is that gap between going outside and then coming back and even being tracked while you're out there. Having a case manager or somebody track that person and saying, hey, what's going on with them? Where are they at? And so what I would just say on that, I'd recommend really quickly would be, make sure that you get releases signed on the front end so you can talk to all these facilities wherever they go when they're still at your facility. Try to advocate or try to get it done as soon as possible so you can keep that communication open, at least know where they're at in the process, because otherwise you have no idea. They don't call us, they don't tell us anything, and we just get totally caught between. So thank you very much for saying that's very important.
And Daniel, given that it was in an urban context, can you talk a little bit of sort of as a psychologist about that sort of companion navigator issue, and then that relationship between tribal programs and urban programs?
Right. Yeah. Yeah. Thank you for the comments. At our clinic, we serve a population with high needs. Many are homeless, a huge percentage in our urban clinic. Many are experiencing a lot of the disconnectedness of living in the confusing LA environment. So for every client that we have a community worker assigned to each client. So they have a counselor, they have a psychiatrist, and a caseworker. And we work kind of an intensive outpatient model, team meetings, constant communication. This client needs to see a dentist. This client is going back to the reservation. How can they link up with a provider there while they're there for the next 2 months while they're gone? So there's a lot of diverse needs. So we try to work and address all of the large amount of needs that our clients have. Just a comment. Substance abuse transfers, I don't experience that a whole lot. We do have a lot of facilities. We have Changing Spirits, a Native American rehab place in Long Beach that's for Native people that we work closely with. Fortunately, we have a rehab center for Native people in LA County that's culturally centered. So we work a lot with them, and they're like 7 miles from us. So we don't work a lot with the remote reservations. But when we do, we do get the releases. We do have the communication intact. We keep in contact with our clients while they're gone. They're able to text us and call us, and our caseworkers make sure that happens. Hope that helps.
Okay. Okay, I'm one of the ones that I really never understood what MAT was. I have 25 years in recovery, and the only thing I knew about was methadone. And a lot of my friends that dealt with that, they couldn't stay clean even with methadone. My whole thing is, how can you have something like this? Because I haven't heard anything this whole time, and even when I do webinars dealing with Matt, what happens afterwards? What happens? I mean, why isn't there something dealing with like meetings, NA meetings, AA meetings, even 12-step wellness meetings? Because one of the things that a person in recovery, abstinence, they have to stop. And you have to have tools to help them stop. And having a drug to help them stop, to me, isn't really helping them stop. So what is there afterwards? Is there something in place to help? Or is that just up to the individual?
That's a great question. I have a lot of thoughts. It's just like saying, hey, you need to lose weight and get in shape. You get a 6-month membership to the gym, done deal. You've lost your weight. You never again have to go to the gym. No, not true. Or you need to keep exercising. I mean, you need to stay on top of your diet. You need to stay connected to the gym. You need to maybe engage in other physical activities. You need to keep it going. It's a lifelong journey. Same with a spiritual practice. If someone goes to a church, you don't say, hey, I got the answer for you. Go to this church for 3 months and it's going to do the job. No, you're going to have to go the rest of your life. If you're going to do this traditional practice or ceremony, if someone says, hey, here's an intervention that incorporates traditional practices, you'll be cured in 6 months. Yeah, maybe you'll stop drugs or alcohol of your choice, but you're going to have to keep going and participating in that traditional practice. That's one. So I think relapse prevention with Native people, we need to create I don't know if we have any formalized evidence-based treatments that say, hey, here's an intervention to lifelong keep you clean and sober. We need to work on that. We need to devise interventions. Most of us probably in this room emphasize the need of staying connected, and we try to find ways in our ways that we treat people to keep them connected, to introduce them to the sobriety groups, to the sweat lodge, to the 12 steps, to coming back to the clinic. In LA, it's unfortunate we don't have community centers that are visible, that clients and the community, never mind those with substance abuse, just for the community members to come and have a place to stay connected with their native roots. So I think we need more structured. I agree with you. It is frustrating. From my point of view as well, we need to find strategies that are more developed for the long haul.
Who is an alcoholic, and alcohol is a poison to us anyway, from the beginning. But you're going to take them from alcohol to a drug. I don't get that, okay? And then what happens after that? I mean, where's the tools to help them not use anything, not only the drug, but alcohol, anything?
Yeah, and thank you. You actually mentioned a keyword, tools. So from my perspective with MAT, it's to help stabilize the physical part of addiction. So it's to gain some stabilization, so while they're engaging in therapy, in counseling, that is tailored to what their needs are, that's where there should be building those psychological and social restructuring and those coping mechanisms, life coping mechanisms, because we primarily use naltrexone or Vivitrol for alcohol and opioid use. Now, in our program, if we just had somebody on Vivitrol for a year and they didn't do any behavioral health counseling, we take that medication away and they haven't done any change, what's going to happen? They're just going to go back to using the coping skill that they know, which is a different medication. So medication isn't necessarily meant to replace. In my mind, MAT is there to stabilize, so in that way they have the space and ability to develop those life coping skills in therapy and also connecting with social services and restructuring their social environment. So that's why it's medically assisted treatment. What is it assisting? Assisting all the most important parts of recovery in therapy, developing life coping skills, restructuring the social environment, which takes a very long time. That doesn't happen over time. That's why Dr. Chisholm was saying like 6 months, we were thinking that's still early recovery. That's still not even, it's just making it into remission. It's not long, it's short term. It's not even long-term recovery yet. So that's the thing that we have to educate our healthcare providers, our communities, even somewhat ourselves, getting that perspective of like, what does that MAT really even mean?
Yeah, thank you. Congratulations on your recovery, by the way. That's amazing. I would say this, it's all in how you look at it, yeah. Yeah, let's celebrate a recovery. I would say this, there's lots of different ways to look at recovery and look at treatment for addiction. The traditional model always was abstinence-based, and that's where we went, but the reality of it is that didn't work very well, okay? And that it worked for you, and that's awesome that it worked for you, but the reality of it is for most people in Indian country, it doesn't work very well. And that's why we're all here, trying to deal with this epidemic. So saying that, I think it's really important that you don't look at it as like, if we had somebody who had a chronic disease and they were getting treated by a medication for that chronic disease, we wouldn't pull it away at some point because we say, hey, you've done enough, you've got your diet back, but if you still need that medication, if you're, insulin dependent, we're going to pull that away because we feel like you've gotten to a place where you don't need it anymore because you've been on it long enough. We don't do that for diabetes. I don't think we should do it for addiction either. Meaning that the statistics show that if you get pulled off this medication, your chances of relapse go way up, okay? I've been doing MAT for 10 years, so I've seen the evolution of it as far as like when I first started doing it, we all wanted to take everybody off it. That was the goal. Put them on it and then start tapering them at some point. Start tapering them down and get them off it. And it just didn't work. And so when we're talking about dealing with this big of an epidemic that's taken over our country, taken over all our communities, we have to get a little bit more aggressive with our treatment style. And I know that doesn't sit well with everybody, but this doesn't sit well with everybody anyway, with where we're at with this disease. So it works. Putting people on MAT works. We know it works. Okay, and keeping them on it long term is where we're at right now with treating folks. In my mind, I think you're absolutely right. When you come on early on and you're very dependent on it, and then later on maybe you're not as dependent on it. And I treat every individual as an individual. Meaning, if somebody comes in and says, "Hey, I want to get off this stuff," yeah, I'll give you every opportunity to get off of it if that's what you want. I'm not going to keep you on it. I'm not going to tell you what you want to do with your recovery. But there's other people that can't do that, or that they realize at some point they wanted to come off it, but now they realize it's just too difficult for them to come off, or they've tried to come off it and they failed several times. And so I would just say it's not as easy to say one shoe fits all in this situation. We had abstinence works for some, MAT works for others, and some people can come off MAT and some people can't. That's how I view it. I think you have to kind of look at it in a very broad spectrum. You can't look at it from one perspective. Okay.
Great. Yeah, and again, just on that, I think that's why we say we're in recovery, because we always know that our challenge continues. Can
I say one other quick thing? I forgot to mention this, that the medication is just one small part of this, okay? And I think that we get so focused in on the medication being this big issue, whether you're on it or not on it, or you're switching one drug for another and all this stuff. Recovery is not the medication, okay? Recovery is life, okay? And that's what we're really trying to get people back into. They can get their kids back, they can keep their job, they can have relationships with their husband or wife, where they can have the family come back into their lives, and they can get trust and honor back in their lives. That's recovery. So I think when we get so fixated on this medication thing, we're kind of missing the big picture quite a bit, because I don't view recovery as, you're no longer taking a drug of abuse. No, you're getting your life back. And that's really what we're trying to offer for people. And you see it when you see people truly in recovery, whether they're on medication or not on a medication. You can see it in their actions and in their face and in their eyes, and you know that they're doing better.
All right. By way of process, then, what we'll do is I've got 4 people on the speakers list, so we'll take get 2 questions into the discussion, and then we'll come back to the panel.
I'd just like to say to some of us that aren't real clear on what naltrexone is, I've learned from Dr. Hall that it's not to get you sober, it's after you get sober. So leading into that, my question for Dr. Chisholm is, you're an IHS facility. How do you prioritize who you accept? And do you also accept members from other federally recognized tribes?
I'll come back to you first.
Okay, hold on. I got to remember which question.
Okay,
so
go
you
ahead.
Said, do we take folks from other IHS federally recognized tribes? That was the second part of your question. We do if they live within the boundary, but we're actually probably going to expand that if we ever do get that 40-bed facility versus a 20-bed facility. And that is kind of the hope for the future, that we'd expand it to all IHS tribes so people could come get referred out from any, really any region to our facility. That's the goal moving forward. And as far as our inpatient psychiatric unit we're building, we're going to keep that same policy within the boundary. Anybody from another tribe within the boundary can get services. And depending on the level of need and how many people that we're serving, then we'll probably potentially expand that as well. It's all a matter if we have enough space, right? Because I really want to treat the folks in Eastern Band, as priority, because they're the folks there. And then outside of that, we got to make sure we have enough beds for other people. So that really depends on a space issue. And what was your first question? I'm sorry, I didn't catch that first one. Yeah. Right.
I have a question. How, or actually a statement and then a question on how to address it. I'm battling within our medical community a perception that research is stating that medication is sufficient and that the behavioral health component isn't necessary. And I'm a psychologist, obviously I'm adamantly opposed to that, but it doesn't matter because from my CEO, medical director, and primary prescriber, that's their view. And I was wondering if you could help me address that somehow.
Well, I do know the research you're referring to. I'll just answer really quick on that. I do know the research you're referring to. I think we're so early on, honestly, in implementing a lot of these programs and seeing what they can do. The research doesn't really speak for the future of addiction medicine. And, you know, if anybody in this room who works with addiction medicine knows that's not true. And going back to what I just said again, medication's a small part of the big picture. And you're not going to get that big picture back by just taking Suboxone every day or taking methadone every day. That's not going to give you back what I'm talking about. You have to work for that stuff. And that means you typically have to be involved with some sort of counseling, some sort of groups, therapy, and really trying to work to get those aspects back of your life where the recovery really matters. So I totally disagree with that. I think that the research is pretty early on that. They're kind of looking at it before we even really know what really works in programming yet as far as treatment with people that are on MAT.
And I have a comment too on that might help out when you bring that back. So a lot of that research is done from the medical model perspective, which is pretty straightforward. You know, their success is they're no longer using heroin, but they're using some other form of MAT. And from that short, narrow perspective, I guess that's an argument. However, as Dr. Chisholm was saying, it's like we're talking about people engaging in life again and getting functionality and relationships. So in my practice, and I'm sure in everybody's practice here, every one of the individuals I see generally are self-treating for an underlying mental health or some kind of trauma. You know, I see the rare case where somebody just got caught partying with the wrong medication and can't get off it. It's very rare. Most of the time, right underneath that surface addiction is some kind of untreated, undiagnosed mental health or trauma that they're dealing with 10 years later or longer. So to come back to the medical providers, just recognizing that, you know, the perspective and argument of self-treating, you know, that there's something that has to be uncovered, addressed, and treated in the majority of the cases, and that's not being done on the medical side.
All right, just before we go, Daniel, so we're going to take these last two comments. Pam has an announcement before lunch. We'll try to wrap up by 12:30. We'll adjust our schedule accordingly.
Yep. My question is for Joel. You described a wonderful system of care with facilities and services and stuff. My question is how in the world did you pay for it, and how do you intend to pay for it long term?
Casinos. That is the tribe has put a lot of their money back into our hospital system as a whole, not just in behavioral health. Behavioral health has been the main focus of the hospital system for the last 5 years. But saying that, like, since the tribe took over the hospital in 2002, they've continuously tried to put their money, tribal money, back into the healthcare system. That's been a huge focus for the Eastern Band. So, yeah, but it's mainly money that they get from casino money that they're utilizing to put back into our healthcare system. But not every tribe does that. So I would say that I advocate for the fact they did that, and it's a good system.
Hello. On the opposite side of the spectrum, the urban areas, man, we need some of this money. The very, very limited funds go to urban programs. So many of the successful programs in urban communities only exist because of these brilliant minds that create these amazing 501c3 operations that help to serve the unique needs of urban Indians. 70% of urban Indians live in urban areas, but very little money is allocated to urban programs. So please forward some of this money over to us, and we'll.
Good? Okay. So Stephen Adams with Connect Tribe in Alaska. I don't want to throw a loaded question at you, so I'll provide a little bit of an explanation, and then I'll ask the question. We recently decided to focus on youth and adolescent behavioral health because there's a gap where we're at in Alaska. And I cannot agree with you more about the partnering. That's what we've been doing, and we've seen a lot of success with that. So we recently came across some state funding for MAT with youth and adolescents. But the issue that we kept running into, so there's not very many providers in the first place. And the ones that we could find were hesitant to offer MAT for youth. Their reasoning was that they were in the experimental stage rather than the addiction stage. And so I kind of just wanted to hear what you have to say about that, and then what we should do or say to develop these partnerships with these providers.
That is a really good question, because that's a very difficult population to treat. We have run into the same issue where we're at, and it's very controversial, whether mainly from the tribe's influence, not necessarily from the evidence-based practice, but mainly from the tribe's influence. They don't really like us putting people who are under the age of 18 on Suboxone. So we've really run into that issue as well. We've had a few folks that are 16, 17 that we put on just because the need was so severe, and we felt like with where they're at with the disease. But the issue that we've come into is the programming wasn't there. So we had potentially put them on the medication, but we couldn't send them to the adult groups. We just didn't feel comfortable about that, just because there was just too many issues within the adult groups compared to the adolescent groups. So what we're trying to do right now is trying to make our own programming that's specific to adolescents, which is, we're still in the middle of that process, but we don't have that teased out yet. But I would say, number one, you would have to have the tribe and the providers that would be okay with prescribing it. But more importantly, I think you're going to have some programming developed to help with the clinical aspect of it, as far as the therapy and the counseling and the groups. I think that would be where the focus would be. But I do agree that there is a place for it. I don't think adolescents should be just like saying they're in an experimental phase. If they're IV drug using, they're doing all the things that we would say from an ASAM criteria that they deserve to have the higher level of care, that we shouldn't give them that. I don't agree with that. I don't necessarily think we should be putting really young kids on Suboxone, but I think, older adolescents, I think they could potentially fit that criteria.
All right, with that, let's see if there's any final comment from our panelists, and then we'll look to wrap up. Any word left unsaid?
Yeah, I'd just like to emphasize the need for comprehensive approaches. In addition, we're talking medications here, but clearly it's a spiritual, mental, emotional, physical disease that we're facing. So we need to really focus equal on the spiritual side, the traditional side, the cultural identity, community connectedness side of things.
Just to echo that and summarize it, and just remember, meet the person where they're at, meet the community where they're at, and I'm kind of just listen. And I think everybody in this room is here in that spirit already. So just keeping that in mind when moving forward with developing these programs.
Yeah, I think we've covered a lot. I really appreciate all the questions, really good questions in here. And if anybody wants to talk to me afterwards, that'd be great as well. I would just say that one of the things that you have to really remember is that thing I mentioned during my talk, that if we're trying to get people clean, we have to give them other resources of activity, whether it's cultural based or anything, whether it's jobs, whether it's whatever. I just think it's very important that we don't just think when we get people on medication-assisted treatment or just in treatment in general that that's going to do it. We have to fill that gap. I don't know if anyone who's been a recovering addict in here can attest to, but addiction's a full-time job, and when you quit actively using, you have to fill that time, and you have to fill it with something. So I just really recommend, as we're doing this, we try to really advocate for as many resources as we can to keep people as busy as we can. Thank you.
All right, thank you very much. As noted, Pam has a quick announcement.
Some of you have signed up for technical assistance, and so if we have Bob Parrish from Pitt River, if you will, before you leave, just step outside and see Charlie Alcaraz. He's the only gentleman sitting there at the table to arrange what time or how you'll do that over the lunch break. Connie Thompson from St. Regis Mohawk can see me, and Sandra Dahl from Leech Lake Band will see Harold. And then we have Kickapoo, if you can come see me so we can arrange your time as well. Thank you.
All right, and I forgot to ask us, let's thank our panelists for their presentation. And please enjoy your lunch. Let us reconvene at 1:30.